Hello everyone, my name is Binoy Chandy. I'm an assistant professor of pediatric otolaryngology at Texas Children's and at Baylor. And today I'd like to talk to you about otolaryngologic airway disorders. So imagine yourself as a first year resident. It's your first day of ENT, and they call you to the ER to see this patient. And he's surrounded by physicians, and they're all very concerned. And basically, they're asking you what to do. So as you can see, he's having a lot of trouble breathing. He's having substernal retractions. You can see his chest wall caving in. You can see suprasternal retractions, and he's getting extra oxygen. So what do you think the first thing you would do? It's sort of a trick question because the first thing you have to do is remember your ABCs and establish an airway, and then figure out why this child is acting like this. So when we think about different common airway disorders, we can categorize them into different sections. For example, we can think of them as congenital lesions, which would include laryngomalacia, vocal cord paralysis, subglottic stenosis or hemangioma. Also infection such as croup, epiglottitis or tracheitis, mechanical like reflux, traumatic causes like foreign body aspiration, and finally neoplastic, such as recurrent respiratory papillomas and malignancies. And it is important when we think about the location of the airway disorder, we have to remember the differences in anatomy between a child and an adult. The airway problem can occur anywhere from the nose, for example, nasal stenosis or choanal stenosis or polyps, all the way down to the larynx and trachea, like tracheomalacia. But the big difference is in a pediatric larynx sits much higher than in an adult. Their epiglottis nearly touches their soft palate. This is why sometimes they're an obligate nasal breather. And another important thing about the pediatric larynx is their cricoid is smaller, and it's the smallest part of their airway. And if there's any injury to their cricoid, you have much higher risk of having airway problems. So in the evaluation of a patient with noisy breathing, you ask about, are they in distress? Are they turning blue? Is it getting worse? We look at the timing. Is it occurring during the nighttime or during daytime? Is it with activity? And changes in position. For example, with Pierre-Robin syndrome, sometimes they do better in a prone position. We also look at feeding. Do they have a coordinated suck and swallow reflex? Are they losing weight? Are they having failure to thrive? Is there aspiration or cough with their feeding? We look at cry and voice. Is it a normal cry? Do they have a weak voice? Is it hoarse? And also look at their birth history. Was it a traumatic birth? That is one reason we look at their voice. Sometimes there's laryngeal nerve injury due to a traumatic birth. So when we look at stridor is basically noisy breathing. It's the noise we make when there's an obstruction and there's turbulent airflow. When it's during inspiration or breathing in, the obstruction is most typically in the nose, the oropharynx, the glottis, or subglottis. However, when you're breathing out and you hear stridor, it's more likely to be in the subglottis or trachea. The reason for this is when you take a deep breath in, there's negative pressure in the glottic and supraglottic area. However, in the tracheal area, when you take a deep breath in, the chest wall muscles open up the trachea and allow more air to flow through. So we can also look at their cry and voice. If it's an infant, the cry is usually normal if there's a lesion above the glottis. Around the glottis or subglottic level, if there's a vocal cord paralysis or a lesion, they'll have an abnormal cry. However, when we look at older children and look at their voice, if there's a lesion in the nose or a pharynx or glottis, they can have an abnormal resonance in their voice. For example, if you have a lot of nasal polyps, you can have a more muffled voice and it can sound like you have a cold. However, if the lesion is below the glottis, your voice will oftentimes be normal. In addition, feeding can be abnormal when the lesion is above the glottis. Like I said before, children or neonates are obligate nasal breathers. So if they have something like choanal atresia, where they can't breathe it through their nose, they'll oftentimes turn blue when they're feeding. So I'm going to go through some of the most common congenital lesions that cause airway problems. And the most common of any of them is laryngomalacia, but also the second most common is vocal cord paralysis. But you can also see subglottic stenosis, supraglottic cysts, and hemangiomas as other lesions that can cause congenital stridor. This is an example of a patient with laryngomalacia. And you can see they have a typical what's called an omega-shaped epiglottis. Their AE folds or area epiglottic folds are short. They have floppy arytenoid processes. So when they breathe in, this area just simply collapses in. As you can see, it completely obstructs their airway. This is a video of a patient of mine, and we can, with laryngomalacia prior to surgery, and we can see how when he takes a deep breath in, this collapses in and it's floppy. This is another lesion sometimes we see. It's called subglottic stenosis. It can be congenital or due to trauma. In this case, you can see complete narrowing of the area right below the vocal cords. Like I said before, the cricoid cartilage is the most narrow portion of the pediatric airway, and this is where trauma occurred and narrowed this child's airway. This is a magnified view, and this opening here is only about 3 millimeters wide. And we had to use a balloon to dilate her airway. And now if we go even further down into the trachea, this is a child with what's called a vascular ring. It's a duplication of her aortic arch, and it goes both in front and behind her trachea to cause a compressive ring. And you can see here how her trachea is compressed down to a narrow slit. And this child presented to the ER multiple times with airway distress. The correction was division of this vascular ring. Now I'm going on to infectious causes. The most common cause is croup, but epiglottitis and bacterial tracheitis are more rare extensions of this disease. So croup is the most common of these infectious causes. The age group is 3 to 12 months of age. Etiology is usually viral. Usually it's the parainfluenza virus. And the area of the disorder is in the subglottic area, where you have swelling of the subglottis. The stridor, as you know from before, is biphasic because it's in the subglottic area. And the presentation is mild progressive distress. Usually it can be treated with just steroids and cool mist humidifiers. And they can typically go home after a diagnosis of this disorder. They typically have a barking or seal-like cough. And this is a picture of a patient with croup. And you can see just below the vocal folds, there's edema and swelling. This is another patient I have had with bacterial tracheitis. As you can see, right below the vocal cords, there's swelling and edema, but this has progressed to a bacterial infection, and it involves the entire trachea, and you can see how the entire trachea is covered with the pseudomembrane. This is a more severe disease, and it's extremely rare, but it requires ICU admission and IV antibiotics. If we go on to supraglottitis, or more commonly known as epiglottitis, this age group is higher. It's in the 3 to 5 years of age. The etiology usually is Haemophilus influenza type B. The site is the supraglottic area, or most commonly the epiglottis. The stridor is with inspiration. It's rapid with severe distress, and often these patients have to go to the OR to be intubated or possibly even get a tracheostomy in place. And typically, the kids are present kids present with drooling because it's too painful to swallow their own saliva. They're in a tripod position in order to extend their neck and get more air entry. Luckily, this is extremely rare these days due to the new vaccination series against H flu. And this is a picture showing a typical epiglottitis. You can see how the epiglottis is beefy red and very thick and inflamed, and it can easily progress to severe airway obstruction. If you have time to get an x-ray, you have this classic sign, which is called a thumbprint sign, where the epiglottis is thickened and it looks like a thumbprint. And we'll also talk about mechanical causes of airway obstruction, which includes airway foreign bodies and esophageal foreign bodies. So this is a normal x-ray with inspiration. And if you look at this x-ray, it is abnormal. And the reason it's abnormal is the left hemidiaphragm is flattened and this left lung is hyperinflated. So it has obstructive emphysema. So even though you can't see the foreign body, you know there must be something obstructing on the left side because there's air trapping. The reason behind this is a normal trachea and bronchi and breathing mechanism. If you look at this picture, when you have a foreign body aspiration, this foreign body is completely obstructing the right main stem, and when you breathe in, air is going around the foreign body. However, when you breathe out, the bronchi collapses and air can't escape from that side of the lung. So air progressively gets trapped in that lung and causes a progressive obstructive emphysema. So as far as foreign bodies, you can see various things in the trachea. It goes all the way from organic objects to nuts. I've seen pins and tacks, etc., in the bronchus. This is an interesting patient. She was diagnosed with croup or subglottic edema, and she was diagnosed with this for approximately 1 month and was treated multiple times and in various ICUs. But when we took her back to the operating room, it turned out she had this foreign body which was lodged in her subglottic airway. And as we take it out, you can see how much edema and granulation tissue has built up. This caused her chronic wheezing. And this foreign body, as you can see, was a metallic piece of confetti that you often see at children's parties and weddings. So it's important also to know that foreign bodies are not always tracheal. They can cause aphonia, airway distress, swallowing problems, and foreign body sensation. Don't forget, even more common than an airway foreign body is esophageal foreign bodies, such as a coin. As you can see in the x-ray, there's a perfect circle, and this is the endoscopic view showing the coin. If the coin is missed for a few weeks, it can turn into an airway issue due to the granulation tissue building up around it. Now, it's important not to miss a watch battery, which can cause esophageal perforation. And one of the signs on an x-ray is a double ring sign where you see more than one ring. And this indicates a watch battery, and which should be removed within 6 hours or so of the ingestion. So other causes include traumatic laryngeal fracture, which is rare, and subglottic stenosis from endolaryngeal trauma, which I showed you a picture from before. Neoplastic causes, the most common cause in children is recurrent respiratory papillomatosis, which is due to the HPV virus. This is a patient with severe respiratory papillomas. And you can see he's having airway obstruction due to the overgrowth of papillomas. These are usually due to HPV type viruses. It's unclear how they're acquired. It may be through the birth canal. However, even via C-section, you may still be able to get this virus. And not everyone with HPV or active HPV will get respiratory papillomas. The way we remove them, we use one of the techniques is to use this instrument called a microdebrider, which sucks and shaves them off. And the typical treatment for someone with respiratory papillomas is to continually remove them on a scheduled basis to prevent airway obstruction. And in most cases, they resolve around puberty. So another cause for airway obstruction, which is neoplastic and malignant, is squamous cell carcinoma, which is the most common type of cancer in the glottic area. This usually occurs in patients who smoke and drink a lot, and usually seen in the adult population. So two things you should remember from this talk. Even though laryngomalacia is the most common cause of stridor, all stridor is not laryngomalacia. And finally, not all wheezing is asthma. Don't forget that to rule out a foreign body in unusual or questionable or patients with questionable history. So if you have any questions, please contact me. My email address is listed above. Please feel free to take a rotation with us, and we can show you all these things in detail. Thank you.